we're going to go ahead and move on. Just for everybody to know, the presentation is recorded. It'll be ready and available to you. My light is really dark all of a sudden. It'll be available to you to go ahead and review after Thanksgiving. So that will always be there for you. So we're going to go ahead and move on to our next speaker. This is just a thrill for me because our next speaker is Dr. Brenda Gonzales. I'm so excited to be able to say doctor now. She just completed her DNP here. I've worked with Brenda for a really long time, so I'm always happy to see her speak. She's a neonatal nurse practitioner with UNM, and she provides care for the infants in New Mexico. For the last 17 years, she's actually been doing this. She completed her doctor of nursing practice in May of 2020. So that's what she did during the pandemic while the rest of us were just at home, making bread. She does have a particular interest in trauma and its correlation with substance use disorder, which we of course see a lot in the state of New Mexico. Unfortunately, it's pretty endemic everywhere. Dr. Gonzales is currently in practice at the University of New Mexico and is the manager of our neonatal practice specialist group here. And she just recently completed a certificate in trauma-informed professional care. So welcome, Dr. Gonzales.
Thank you, Kathy. It's such a thrill to be here with you. I see lots of familiar names. I'm excited to see you. I'm looking forward to next year when we can hang out in person. Kathy, could you let me know? Can you see my notes?
Not yet. You have to share them. So they're at the bottom of the screen.
Oh, I have to share my screen. I did my whole doctorate online and promptly haven't touched my computer since.
Oh, there. And perfect.
Now it's like training me again. Now can you see my presentation?
It looks beautiful. Thank you.
Okay. Thank you, guys. As Kathy said, my name is Brenda Gonzales. I've been asked why, I'm a neonatal nurse practitioner. Why is my area of research interest maternal opioid use? I have to admit, I've been doing this for a few decades as a nurse and a nurse practitioner. And when I started as a nurse, we just didn't see neonatal opioid withdrawal. I never really took care of one as a nurse. When I became a nurse practitioner at a different hospital, we'd see a couple a year. And now, as you all know, it's just kind of like an avalanche in the last 10 years or so. Back in the old days, we didn't really have any protocols. We didn't know how to withdraw these babies. We were just kind of winging it. So I'm focusing on the issue of maternal opioid use because it has led to this increased incidence of neonatal opioid withdrawal syndrome in the U.S. and quite particularly in our state, and I'll show you why. In the course of trying to manage these withdrawal symptoms, I've noticed a lack of understanding related to addiction and how this impacts the care that we give these families. I can actually remember the moment. It was a few years ago, and it happened as I was struggling to find a topic for my research when I was in my doctoral program. One of the residents walked into the team room, and she said, "The next drug mom I see, I'm going to punch in the throat." And I have to be honest, I got it. I understood, it's really frustrating. We love these babies. They're our patients, and it hurts us to see them in pain. We're afraid of some of the home situations we send these babies to, but I thought there had to be a better way, and this is what I learned. I have no financial interests or relationships to disclose. The objectives of my talk today are to analyze the link between interpersonal trauma and opioid use disorders, and to discuss the aspects of OUD in the context of pregnancy, delivery, and hospitalization of the infant in withdrawal. And I want to examine trauma-informed care as an informed approach to improve outcomes for the opioid-exposed maternal-infant dyad. The purpose of this presentation is to discuss the increasing incidence and complexity of OUD in these pregnant and parenting women and how it's caused a marked increase in the occurrence of neonatal opioid withdrawal syndrome. Probably going to start saying OUD and NOWs a lot because that's a mouthful. I want to talk about how social stigma related to addiction and the lack of understanding into the origins of opioid use disorder in general can negatively impact the care of these neonates and their families. There are a growing number of studies that have examined how the experience of caring for infants with NOWs and their families leave nurses feeling frustrated, distressed, resentful, angry, and inadequate. This results in compassion fatigue, and this further complicates the care relationships of these families. This is the most recent information I was able to find on NOWs in the US and New Mexico. It's a few years old, but as most of us are aware, the research says that the current opioid crisis basically began in the 1990s with the overprescribing of opioids. I want you to focus on this graph starting around 2008. You can see represented by the dotted line, that's the United States, there was about 2.6 of 1,000 infants born in the US in opioid withdrawal, increasing to 8.6 in 2017. That's a 207% increase. New Mexico, represented by the solid line starting in 2008, showed 3.3, which was just above the national average. Currently, or most recently in 2017, it's gone up to 14 per 1,000 births. That's an increase of 324%. That is well above the national average. I want to shift gears now, talk about trauma and how this contributes to the use of opioids. When I say trauma, I'm referring to an event or a series of events that has caused a person to feel physically or emotionally threatened. This sense of being threatened varies from person to person. What causes us to consider that trauma may have occurred is the response the person has to an event, the reactions of feeling threatened or feel fearful or helpless. We know trauma is a widespread, harmful, and very costly public health problem. It occurs as a result of abuse, violence, neglect, loss, disaster, war, and other emotionally harmful experiences. Someone who experiences trauma will realize the fear a person shows as communicating something important in that history. That's something that we all need to get better at. What the research has shown is that the effects of trauma linger. I mean, we've all heard of PTSD. The experience of trauma may weaken a person's ability to cope over the long term, as well as overwhelming their capacity to cope in the short term. As caregivers, we need to remember that trauma has no boundaries with regard to age, gender, sex, race, ethnicity, socioeconomic status, geography. It's a universal experience for people with behavioral and substance use disorders. I want to emphasize that the person who experiences trauma decides if an event was traumatic or not. It's not for the perspective of the healthcare provider. Now, childhood trauma has been shown to be a major risk factor for the most common causes of adult illness, death, and disability in the U.S. I don't know how many of you have heard of the Adverse Childhood Experiences Study. It was published in 1998 by Folletti et al., and it showed remarkably high rates of childhood physical and sexual abuse, neglect, and household dysfunction among 17,000 predominantly white middle-class adults. The study calculated an ACE score of 0 to 10. You can see there's 10 categories here on the slide. And that's based on how many categories of childhood abuse the individuals experienced. 64% reported at least one ACE category, and 1 in 6 reported 4 or more. Women were 50% more likely than men to have experienced 6 or more categories of ACEs. The study also revealed a strong dose-response relationship between childhood trauma and adult heart, lung, and liver disease, obesity, diabetes, depression, substance use, sexually transmitted infections, and intimate partner violence. For example, individuals who reported 4 or more ACEs had 3 times the rate of depression, at least 3 times the rate of alcoholism, and 11 times the rate of IV drug use, 14 times the rate of attempting suicide than those who reported an ACE score of 0. The most harmful trauma experiences for children tend to be those that were perpetuated by someone close, usually well known to the victim, and were intentional, repeated, or prolonged. It's important to note that the earlier in life that this trauma happened, the more profound impact this has on the child's brain development. This is important because before age 5, children's brains, they're in this critical period of development. Positive experiences can lead to healthy brain development, while negative experiences can promote unhealthy development. Prolonged trauma can decrease the volume of area of the brain responsible for cognitive functions such as short-term memory, emotional regulation, and higher cognitive functions. So we all know that San Diego is awesome. And as I said, that was a predominantly white study. So I found another study called the Expanded ACE study. This was done in Philadelphia. And this kind of contrasts the two different studies. While there were more people in the original ACE study, the Expanded ACE study was much more diverse and represented many more different types of people. It was conducted in Philadelphia, and as I said, although they only surveyed a 10% sample of the original study, it had a racially diverse sample of adults who had only completed high school, so very little advanced education in these folks. The original study reported 30% of people had no ACEs, while in the Philadelphia study, 16.8% reported no ACEs. So that's half, almost. In the original study, 21% reported 4 or more, while in the Philadelphia study, over 37% reported 4 or more. This demonstrates that although adverse childhood experiences or events occur in all socioeconomic groups, they're far more common in low-income and minority populations. As I said before, there's the dose response relationship with later health problems. These are a lot of the health problems that folks can look forward to if they have a lot of ACEs. They have lasting negative effects on health, well-being, in addition to like life opportunities such as education and job potential. Trauma experiences increase the risk of injury, sexually transmitted diseases, maternal child health problems, including teen pregnancy, pregnancy complications, and fetal death, involvement in sex trafficking, and a wide range of chronic diabetes diseases, including cancer, diabetes, heart disease, and suicide. Children growing up with toxic stress may have difficulty forming healthy and stable relationships. They may grow up to have unstable work histories and struggle with finances, jobs, and suffer from depression throughout life. These effects can also be passed on to their children. So I wanted to talk about this national report released by Child Trends using data from the National Survey of Children's Health, showing New Mexico has one of the highest rates of children suffering from adverse childhood experiences. We're tied with Arizona at 18th, with a national average of 11. So almost every 5 children suffers between 3 and 8 ACEs. This is important because of the result of this multiple and chronic trauma to these children when they're little. This must be on a timer. Can result in chronic toxic stress. So I know you all know about the HPA access. You're familiar with it. I'm just going to review it quickly. We know that periods of stress or trauma activate this HPA axis. It releases cortisol for several hours, prepares our body for fight or flight. The adrenals release adrenaline. The adrenal cortex converts norepi to epi, and the combined effects of the cortisol epi and the norepi engage system-wide defense mechanisms against the stressor, fostering mobilization through the secretion and distribution of glucose and stored energy. This is super helpful if you come across a bear in your backyard. However, if there's a bear at the kitchen table or in your bedroom every night and you're under constant stress, your body habituates to the repeated and sustained activation of the HPA axis. Eventually, there will be muscle breakdown, a decreased inflammatory response, constantly circulating excess cortisol, and negative health effects. This is what I refer to as chronic toxic stress. Over time, exposure to chronic toxic stress will alter your DNA. As I've already said, the development of an OUD is highly associated with past or current psychological trauma. Over 90% of people with OUDs report this type of history. Intimate partner violence and sexual assault are very strong predictors for subsequent substance use disorders as well. When considering a person with an opioid use disorder, it's really important to emphasize and understand addiction is not a choice that anybody makes. You can ask any child anywhere at any time, do you want to grow up to be a drug addict? And they won't. We all know that they probably won't know what that is, but the answer is always going to be no. It's not a choice they make. It's not a moral failure. It's not an ethical lapse, and it's not a weakness of character. It's not a failure of their will. Addiction is a response to human suffering. They're trying to respond to the constant negative feelings that they've been exposed to. Despite a plethora of research that shows it identifies addiction as a pathophysiological disease, it continues to be perceived by many healthcare providers and society as a whole as a moral failing. So it's important to note that when defining and treating addiction, there's a significant variation in approaches and resources related to gender. It is true that more men use opioids, but biologically, women become addicted much more quickly and with much less amount of the drug. In addition, North American social standards and expectations related to substance use are much harsher for women. In society, in the media, women who use illegal drugs, they're portrayed as amoral, sexually promiscuous, and deviant. In spite of this, historically, women and girls have been encouraged to self-medicate for emotional and physical symptoms. Over the past century, physicians have regularly prescribed medications, including opioids, stimulants, anxiolytics, and antidepressants, more to women than to men to treat symptoms of moodiness, fatigue, pain, anxiety, and depression. And then once these women are dependent on medication to function and it becomes a problem, they face additional barriers to treatment that men usually don't face, such as lack of childcare, fear of losing their children, and they have fewer resources to pay for this. So what is stigma? We're all hearing about it. We're all getting a lot of training about implicit and explicit biases. But I just wanted to define it clearly. Merriam-Webster, just a plain dictionary, it defines it as a mark of shame or discredit. However, I found a more robust understanding and definition found in the APA Dictionary of Psychology, which describes it as a negative social attitude attached to a characteristic of an individual. Stigma implies social disapproval and can lead unfairly to discrimination against an individual and can result in their exclusion. Zwick et al. Remark that stigma frequently results from assumptions, misconceptions, and implicit or explicit biases, and that this can be an insidious experience which envelops the existence of individuals with substance use disorders. Stone in 2015 remarked that individuals with substance use disorders are often viewed as being more dangerous and unstable than individuals with mental health disorders such as schizophrenia or depression. The stigma that results from opiate use disorder isolates individuals by labeling them as different, and this is magnified in the context of pregnancy. There's a false belief that women are unconsciously harming their unborn babies. I have to admit, I've done this myself. So I wanted to talk about the perspectives of some of the nurses and providers who care for these babies. We discussed how the women are more dependent on medication. They're overtreated for symptoms and they're given drugs to function. Now we have their babies withdrawing in the NICU. And what does the research show about that? A growing number of studies examining the experiences of nurses caring for these infants with NOWs and their families identify that the nurses are distressed, frustrated, resentful, angry, and inadequate. Some of these perspectives include that this stress is related to perceived maternal defensiveness. That's probably the number one thing that I hear and that I've probably experienced is that these moms are extremely defensive. But they've had to learn how to be that way. We have to remember that. Their concerns. So the nurses are perceiving maternal defensiveness and they're concerned for the infant's health and discharge or safety after discharge. The nurses are also exhibiting role confusion. The baby is their patient, not the mother. They report ethical and moral distress and compassion fatigue and the frustration in the mundane role of caring for withdrawal infants. It's a mundane task, but we also know it's really hard. So I've shown you some of the frustration from the nursing provider viewpoint. This can lead to compassion fatigue, particularly with increasing rates of NOWs. In a 2017 review article, Swigert described compassion fatigue as a unique form of burnout resulting from interactions and relationships with people in need of help. It's not necessarily as a result of the work environment. We always blame the work environment for our burnout, but often it is just the exhaustion from taking care of people. Compassion fatigue and burnout are associated with increased turnover, nurse attrition, and decreased engagement. Lack of awareness of compassion fatigue symptoms and strategies for prevention impact the individual nurse, the workplace, patient care, and can often lead to disengagement, decreased productivity, safety concerns, and even stress at home. We take this home with us a lot of the time. Now let's examine the perspectives of pregnant and parenting women with opioid use disorder. Research shows that they feel they receive judgmental verbal and nonverbal reactions from healthcare providers that resulted in them feeling excluded from the care of their infants. Concomitant psychological distress is common during the perinatal period because these women are often dealing with CYFD, family conflicts, treatment programs, the stress and guilt of a baby withdrawing in the NICU, on top of potential postpartum depression. In New Mexico, we're such a huge state. A lot of these women are displaced from their community. They don't have the money to drive to Albuquerque. Sometimes they don't have a car. The inability to cope with these emotions and stress may perpetuate this defensiveness that we feel geared toward us and result in decreased visitation because we feel it, then they feel it back from us, and they start to disengage. And that causes a trigger for relapse in these moms in a very precarious time in their life. And it also results in the perpetuation of this constant stereotype. The literature's pretty limited on the maternal aspect of substance use disorders and mothering, but I found one small qualitative study by Cleveland et al. On the mothering experiences of women with substance use disorders that I wanted to spend a little time on because I felt like it made their experiences more impactful for us. There were 5 major themes identified by the authors. The first theme identified was facing the reality of a pregnancy complicated by substance use, trauma, and loss. Pregnancy was often an unintended event for these moms. They felt an urgent need to address their substance use disorder, but they were unable to abstain because they were afraid of withdrawal, and they knew that abstinence would also jeopardize their pregnancy. The second theme involved managing the details of the everyday life, which I just kind of went through on the previous slide. The third identified was dealing with the consequences of their substance use. It was painful for these women to see their infants withdrawing. It caused them stress because they were unable to console their own infants. Interactions with the NICU nursing staff were particularly stressful. One mother described how badly it hurt her to overhear a nurse refer to her as that junkie mom, describing how she avoided the nursery altogether if that nurse was on duty. Another mother said, "You're not a very strong person when you're in the midst of your addiction." So feeling unwelcome in the nursery can be like a trigger. And it's easy to be like, you know what, they don't want me to see my son, then I'm not going to see my son. I'm going to keep using it and leave him there and never go back. We've seen that a few times. The fourth theme focused on trying to find a higher meaning in their pregnancy, describing how being actively involved in their infant's care helped these mothers face the consequences of their substance use while also bringing them comfort as they tried to care for their baby. And finally, the fifth theme identified by the study was looking toward a future with their children, centering on the mom's desire to keep their children with them. One mother saying that keeping my children is my reason for staying clean. I'm willing to fight my addiction for the rest of my life. This study was congruent with other research findings. The women viewed their pregnancy as a catalyst for change that provided a window of opportunity for recovery. This information provides nurses and other healthcare providers insight and hope into the powerful role motherhood might play as a motivator for women with substance use disorders interested in seeking treatment. I was told by this wonderful doc, she's a pediatrician, and she said, when I talked to her about what I was thinking to do for my research study, and she says, "Brenda, there's going to be 3 kinds of moms. There's going to be the moms who really, really want to change. There are going to be the moms that are like, this doesn't change anything, and that's that. And then there's going to be the moms in the middle." So I was hopeful that we could reach these moms that really, really want to change, and hopefully a lot of the moms in the middle, and maybe make this experience of having their children in the NICU for the moms who don't want to change at all, maybe change their minds. I would have to admit that she was right. In my experience, this is what I've seen. So trauma-informed care. I had honestly never heard of this. Like I said, I've been out of school for a million years until I started my doctoral program. I stumbled upon it accidentally. I was trying to figure out my topic. I stumbled onto adverse childhood experiences, and I started researching trauma. And then I came across this trauma-informed care, and I'm here, what is this nebulous thing? So I'm going to do my best to explain this to you and give you some examples. So we have all this research that shows the relationship between trauma and opioid use disorder. Trauma-informed care has kind of emerged from that. It's an important mechanism for healthcare providers to help care for these folks. It's a strengths-based framework that emphasizes physical, psychological, and emotional safety, not just for the baby, but for their parents and for each other, for us, the care providers. Basically, trauma-informed care is an approach that assumes that an individual is more likely than not to have a history of trauma. Now, social workers, psychologists, addiction specialists, they've all been doing trauma-informed care for a couple of decades, like over 20 years. And despite evidence that trauma is so pervasive and has so many bad health outcomes, the healthcare field has kind of lagged behind in recognizing the benefits of providing trauma-informed care. It still lacks a standardized method of educating healthcare professionals in its principles. As the substance use and mental health providers can say, it's an important tool in the screening of individuals with opioid use disorders, but it can also be used as a framework for which healthcare can use it in the same way that we will not re-traumatize this person. One of the principles is re-traumatization. We don't want to re-traumatize them just by trying to care for them. And we'll get more into that in a minute. It's kind of similar to providing universal precautions. Trauma-informed care must become second nature to healthcare professionals interacting with all individuals, not just the parents, not just the patients, not just your husband, but yourself and the people that you work with. It represents a paradigm shift, basically. Instead of saying, what's wrong with this person, we say, what happened to this person? And it really changes the way inside. If you do that every time you come upon someone, you will feel the difference in the way you approach them. It becomes really important when you are dealing with this poor woman that just had a baby, has an opioid use disorder, the potential vulnerability that these women are going through during pregnancy and childbirth frequently triggers trauma from before. This type of supportive care should extend to the NICU in the care of the withdrawing infant. When we're viewing people more as a whole person who has had life experiences rather than a caricature of their current behavioral reactions, then we start to make another shift from being stressed out by this person to being more empathetic. This allows us to shift, as I said, our behavior. So there are 6 key principles of trauma-informed care, the most important of which is safety. These families need to feel safe when they leave their babies with us in the NICU. Nurses are key to this because they have this compassionate background. They have the ability to remotely address any concerns. They can act quickly as liaisons between providers and parents. Nurses are key to this. Trustworthiness and transparency is also important when there's a history of trauma. Women are afraid to seek medical care because they lack trust. Transparency of the care and interventions for their baby will help build this trust. I just noticed I'm running out of time. But no, I have till 10, I think. Sorry, I won't rush. We need to give these folks clear information. We need to talk about the good, the bad, and the ugly. We don't need to focus on trying to trick them or catch them saying something that's going to get them in trouble, or we're going to tell CYFD. So be transparent. Whenever possible, choice and collaboration kind of go hand in hand. You want to prioritize the parent's choice and control in the decision-making process whenever possible. You know, we've had parents saying, no, methadone is terrible. Can you please use morphine? Well, we can do that. Even if it's something like, oh, my other child didn't like that kind of formula, and can we try this kind? Yes, we can. It gives them a sense of control over their child's path through the NICU. And that's so important. And we'll talk about why. Collaboration. We need to maximize this through the sharing of power, like I just described. Shared expectations. And sometimes you just need to walk up and say, how can I support you today? What can I do for you? It goes a really long way. Empowering these parents by encouraging them to advocate for their children when we take their sometimes small needs like formula choice and say, sure, we can do that. It empowers them to have a voice for their child. It gives them the sense that they know what's best for their child, and they're going to take this ability to advocate into their child's childhood, hopefully making it better than maybe theirs was. It also encourages them to build on their strengths, and it helps promote resilience. A lot of these folks struggle with that. And it's always important. Cultural, historical, and gender issues must always be addressed by moving past stereotypes. And I really love how the current climate is that we're all learning about how damaging that can be when you judge people on a characteristic such as their gender issue or sexual preference, all of these things. I really love how we're becoming more empowered in that area. There's all kinds of families, and it's not for us to judge. We're just there to take care of their baby and help them get home with this family who loves and wants to take care of this baby. One of the things when I wanted to become trauma informed, I was looking for a checklist. I wanted something to say, do this, do this, do this, do this, check it off every day. And there's just not one of those out there. It's more of a thing that it requires constant attention, caring awareness, and sensitivity at all times in all interactions with everyone. Through ongoing assessment and quality improvement, trauma-informed care needs to become embedded on an organizational level. And that's a lot of places aren't there yet. The implementation, there's the 4 R's of trauma-informed care. The first is to realize the widespread impact of trauma, which I've talked about in depth today. I've gathered data for our state. We know we have high ACEs. We can look into mental health, trauma and violence issues, conduct a retrospective review of discharge data of your own unit to learn the scope of the issue in your community or your hospital. Talk to community partners. We have a couple of really awesome programs at UNM. And I'm not plugging them, but I am. We have the Milagro and the Focus programs at UNM, and they collaborate together. They work together. We have these women with substance use disorders. They seek care at Milagro. They're seen by the maternal child health team. The maternal child health team takes care of them through their whole pregnancy. They're getting counseling and methadone supplementation or buprenorphine, whichever. And then they come to the hospital. They deliver their baby. These MCH folks help deliver their baby. And they also staff the unit where a number of the withdrawal babies go. It's called the ZIA team. And then these babies are seen at the Focus Clinic, and the Focus Clinic works with the Milagro Clinic to combine the appointments because we know that transportation is a huge issue. So that's a really, I just had to include that because it's just such an excellent program that we have, and how it combines the different tasks in caring for this family in a way that these folks who are very distrustful of the healthcare system feel more comfortable, and they actually do come to their appointments. So we need to recognize the signs and symptoms of trauma. For example, review current resources, share information at staff meetings. That's what I tried to do with my research that I did. Invite women who have recovered from substance use and have their infants in the NICU to come to team meetings. I know a lot of this stuff hasn't been possible with COVID. Respond in a trauma-informed manner. Now, that's something that we can do. We used to give a lot of NICU tours. That kind of went away with COVID. But when these moms show up, give them a welcoming tone. Integrated, consistent from all team members, from the lady at the front desk to the nurse to the providers. Give them clear information about services. Be really transparent about what we're going to do to manage their baby's care. Use first-person language. I'm going to talk more about language in a minute. Don't call them manipulative, uncooperative, or drug seeking. Instead, you don't even have to say it, but just think it. They have survived trauma. They've developed survival skills. A lot of them are maladaptive, but they've developed them, and that got them this far. Recovery is going to take time. Shift from what is wrong to what is happening and integrate this with every interaction. So here's a comparison of traditional and trauma-informed approaches. So traditionally, traumatic stress is not seen as a primary defining event for people. Well, some people manage traumatic stress differently than others. But traumatic events are central events, and they do impact everything else. We all have a different response. We don't know what everyone's response is. It's not definitely always going to be the way that I would have responded or you would have responded, but they have a response, and that belongs to them. Problems and symptoms are discrete and separate. No, they're not. They're interrelated responses. These are coping mechanisms, and they've developed them to deal with the things that they've faced. I'm not going to read all of these to you. I'm happy to send these slides out, but just remember to act in honest and humble ways. Treat the patient and the family with dignity by indicating that the baby is at the center of the caring relationship. We need to build therapeutic and healing relationships with with our babies. We do. Families, their extended families, which are finally getting to come back into the NICU, shift away from this task-oriented thing. That's something that nurses, I know I was very task-oriented when I was a nurse. Sometimes that's all you can do to get everything done. But shift away from that mindset to a relationship-based model of care. Build rapport with these families, promote trusting and safe relationships. A good way of doing this is primary nursing. Primary nursing is excellent for this. Be intentionally present to create an authentic caring moment. If these families feel that you're in their corner, they will believe that you're doing the best for their baby. And honestly, that's what we should be doing. Very importantly, adopt self-care strategies that nurture wholeness. Get adequate sleep, optimal nutrition, take walks outside, engage in supportive and loving social networks. Self-care is very important if you want to be able to care for others. And then examining our use of language. As I said, that in that one study, the mom got called a junkie mom, and she never came back when that nurse was around. Instead, say a person who uses substances, person in recovery. Use person first language, focusing on them before their condition and behavior. Don't call it a drug habit or a drug addiction. It describes substance use as health-related and changeable, not as a habit or intractable. Replacement, again, I'm not going to read all of these to you. I have heard drug babies a lot in my life. That just, if it were me, that would make me feel terrible. I think most of you know that these women cannot just completely abstain from drug use. That will put them in withdrawal and will risk their life and the baby's life. So even if they want to change during pregnancy, is not the time that they can change safely. So we need to remember that babies are not addicted. They're born physically dependent. So all of these little things we can do every day to help us against this larger than life kind of problem that we seem to be in the middle of. We should use words that empower others to inspire themselves to be their best self. Use person-centered language that is respectful of the dignity, worth, and uniqueness of every individual. and avoid using acronyms and medical jargon. This helps to facilitate and foster a person or a centered, relationship-oriented dialogue. I wanted to share my favorite quote. While we still have time, let us do good. I feel like every day gives us an opportunity to help someone else. Don't pass that opportunity up. It could be something as small as helping someone with their groceries, or, pushing the walk button when you get to the other side of Loma so that the people coming on the bus behind you don't have to wait so long. Just do good things. I hope that this presentation has helped you towards that. And with that, I have my references, and I am happy to take any questions.
Thank you, Brenda. I have a couple. Somebody was asking for a better definition about the difference between NAS and NOWS. Are we using those pretty much interchangeably, or are they being applied differently to different situations?
So we used to use NAS for everything, and then we realized that the constellation of withdrawal symptoms are different. So we're really trying to separate neonatal abstinence syndrome from NOWS. NOWS should be used for babies who are opiate exposed. NAS, the NAS is kind of on its way out, but you still see it. I still see it a lot in the literature. It's those old dogs learning new tricks like me. It's hard for us.
It happens all the time. I feel that when you leave for 2 seconds and they change all of the acronyms on you, you're just like, oh my God, what's going on now? What does that stand for? I have to look it up. Thank goodness for Google. We are going to have a discussion. Kara's going to actually talk to us. That's a nice segue from your talk to how we're throughout the state, how we go ahead and help our families. There is somebody who, this is a very interesting comment that Myrna made. She says she feels that after listening to this amazing presentation, she realizes the collusion between Big Pharma, Purdue Pharma, that's the big one, right? Them and their fentanyl thing. And sometimes unwittingly our providers in the development of substance use, I don't know what the O stands for, and opioid use disorders. And that she feels like the NOWS graph was very chilling about, that sharp increase that we had throughout the state. The medical model in collaboration with corporate greed helped create a generation of mothers and children suffering from the effects of drug abuse, which is true. Thank you for sharing a path forward through the model of trauma-informed care. I will say overall that we are hearing more about trauma-informed care. I actually read a comment. I was on Reddit one day, and somebody was just very happy that she found a provider, an OB provider locally, who listened to her about her trauma having to go through her pap smear. She had stuff that had really traumatized her in her past, and she couldn't find anybody who would sedate her for this. And she finally found somebody who listened to her and was like, yeah, we'll sedate you. We'll sedate you and hold your hand to make sure that you're doing okay so that you can get your routine care. So I think that a path forward of recognizing that our moms are suffering from trauma, and how can we not only prevent from harming them more, but help them with a path through, I think is a really great thing. And I'm really happy that you're doing this work for us, Brenda.
That was a really good example you gave of resisting re-traumatization. So simple, and but so important. So now this lady can continue to get her care. I just want to thank you all so much for your positive feedback. This kind of became a passion of mine. It's not going away anytime soon. I think it's devastating, as Myrna said, the path that the part that Big Pharma played in this. It's really disgusting, and now we just have fentanyl just pouring into our country. And I mean, if you think about it, the just opioids, fentanyl overdoses, it would be like the equivalent of a 737 crashed every single day in our country. That's how many people will die today. A whole plane full of people will die today of opioid overdoses. And if we can do all our little part, it just doesn't take much. I have found sitting down with these moms, don't talk over them. Sit down with them, pull up a chair, and just ask them how they are, how they're doing. What can I do for you today? What's stressing you out right now? Those things go a really, really long way. And I know it's really hard to talk somebody into primarying a withdrawing baby. We have so many great nurses that work in the intermediate care nursery that are so good at this. The NICU nurses, we'd rather have a baby on an oscillator with 16 drips than a withdrawing baby. But was there any more? Oh, Connie Pisani. As far as I know, there is not trauma-informed training at UNMH. I think that would be awesome. But no, as far as I know, there's not. You'll find little lectures if you search the unm.edu website, put out by I think there's a psychiatry fellow that put one out, but nothing formal. And I would love to see it. I kind of feel like it's a bad time to push this because the flux of nurses are still kind of coming and going from COVID. So we need to stabilize that quite a bit before we can, put this. What I would love to see is that it starts in nursing school. That's what I would love to see.
We could
medical school.
Really move towards that. I think all of our hospitals could probably start moving towards education on trauma-informed care. That way it's ready to launch whenever our nursing situation does stable out for the most part. And even if it doesn't, I think that this is a good thing to let everybody know about. Maybe they can take it with them to the rest of the country. It'd be great. So